A little bit about me. Before I got into risk management about 20 years ago, I was a medical malpractice attorney and then went in-house at the California Medical Association. I'm licensed to practice in Minnesota and California. I currently live in Minneapolis, Minnesota, where we just got 1.5 feet of snow. So I'm happy to be down here seeing the beautiful blossoming trees. Even though I am a licensed attorney in 2 different states, I'm not licensed in California, and I can't give legal advice. So what I'm saying to you tonight is simply risk management advice, recommendations, risk reduction strategies, that kind of thing. If you would like a legal opinion, I would ask that you go to your hospital attorney or whoever you use to get legal advice. So hopefully this documentation presentation is a little bit different than what you're used to. I'm focused entirely on how documentation can hurt or help you in a malpractice lawsuit. And here are our learning objectives for CME. And we're going to learn to recognize the significance of documentation in liability risk reduction, identify situations that increase the risk of inadequate or inaccurate documentation, and implement risk reduction strategies to mitigate professional liability and enhance patient safety. I'm going to use case studies and risk reduction strategies to hopefully meet these goals. The case studies are based on real incidents from our closed claims, but the facts have been changed to protect the identities and facts and things from the lawsuits. You're also going to hear pre-recorded commentary from Dr. Frank McGeorge about how to put our risk reduction strategies to work. Here's Dr. McGeorge, who's been an emergency physician for over 30 years. In addition to clinical practice, he teaches in medical school. He's been published in medical journals and has been interviewed in print, radio, and television as an expert on multiple medical topics. He's even received 5 Emmy Awards. Dr. McGeorge is an expert witness in medical malpractice cases, and he's been deposed numerous times and frequently testified in medical malpractice cases. So I'd like to hand it off to Dr. McGeorge to tell us what his thoughts are about learning from case studies.
I've been practicing emergency medicine clinically for the last 30 years. I actually started with a strong interest in education and became residency program director at one of the largest medical centers in the state of Michigan and remained in that position for about 10 years. And over time, my interests evolved and I pursued a slightly different avenue with the media, in addition to continuing my clinical practice. When you review cases, you have to put yourself in the position of the provider at the time. So you want to do it in what I call a blinded fashion. In other words, you don't want to know the outcome. You look at the material and you see whether or not it fits with what you might have done or with what the standard of care is. That is really what an ordinary physician would do under the same or similar circumstances. And I think that's an important element because, frankly, there are so many times when you review a case that may sound horrible, but you look at the facts and you say, that could be me. That could be any of us. That is just the way medicine is practiced. And I think that's what makes it so important to look at things objectively. But to be fair, we don't always know the outcome when we're practicing prospectively, when we're seeing a patient. And so it's interesting to always see the outcome. And sometimes they are very adverse, tragic outcomes, I admit. But they are through no fault of the physician. They are just something that happens, either an expected complication or just a random event that you couldn't have controlled for. And that's why I think it's interesting to me, because I learn about all the possibilities that could happen, the permutations that we can't predict. And as an educator, that has helped inform me in teaching residents what to think about, what to look for, and how to protect themselves in perhaps maybe worst case scenarios that they might not necessarily think are that common, but could still happen to them.
So we reviewed the medical professional liability data to see in dollars how much lack of communication and failure to document that communication can cost. The average indemnity payment, which is the amount paid to the plaintiff, is well over $300,000 per claim. And while most of you probably have malpractice insurance coverage for $300,000 or more, every payment by your carrier can increase your insurance premiums, and it is reportable to the National Practitioner Data Bank. And unlike cases involving unexpected outcomes, communicating and documenting that communication is something that is under your control. So things may feel very out of control on a busy day, but your documentation and communication is something that is all yours to win, as it were.
A cornerstone of good practice of medicine is communication. And that's communication with patients, it's communication with your colleagues, it's communication across the board. There is an element of, I'm going to say, pain in the electronic medical record, because documenting does take a lot of our time, and it's frankly kind of painful. But it's something that's critical for a lot of reasons. First of all, you need to bill for the encounter. You need to communicate. In my case, in the emergency department, we need to communicate with other providers that might take care of the patient after us, or we need to communicate with the primary care physician through the chart. We also need to document the encounter for medical legal reasons, and that's just a fact. And those are the three key elements that I think go into our documentation. None of them is more important than the other, but you need to consider all of them when you are creating a paper chart, or in this case, really nowadays, an electronic chart.
According to recent MPL data, the most common specialties involved in claims for errors in The most common specialties involved in claims for errors in documentation and communication are OBGYN surgery, internal medicine, plastic surgery, family medicine, and radiology. So, in line with the data that I just showed you, our first case study deals with a documentation failure in an incident that occurred during labor and delivery. So in this case, a 25-year-old maternal patient was admitted to labor and delivery for induction at 39 weeks of gestation. Once she began pushing, the patient changed position after 30 minutes and again at 90 minutes to try and progress. After consultation with the labor and delivery nurses, the OB discussed with the patient the need for surgical assisted delivery and recommended the use of forceps. The physician documented fetal malpresentation as the reason for the forceps delivery. The OB did try to rotate the baby prior to using the forceps, but was not successful. With the first pull, the baby descended slightly and was delivered on the second pull. The laceration to the mother occurred as the baby's head delivered in occiput posterior position. Fortunately, there was no injury to the child. While not documented, nurses testified at deposition that the mother was growing tired as her delivery progressed. The OB testified from memory that she repaired the laceration with 4 sutures, although that was not documented. The patient was discharged from the hospital after 2 days. On the next day, she arrived in the ED, reporting loose stool discharge from her vagina. ED staff performed a soap suds enema and an exam, at which time a fistula was discovered. The patient was taken to surgery, where the defect was repaired. However, she suffered several breakdowns of the wound and ultimately required a diverting loop ileostomy to allow the tissue to heal before a permanent repair could be successful. In a lawsuit filed by the patient, she alleged negligence related to the use of forceps as a contributing factor for the laceration and complications related to its repair. Unfortunately for the OB in this case, there is only one entry that says anything about the use of forceps. There is no further explanation regarding her rationale for using forceps. And you can see here that this is likely from a template and only the most minimal information has been recorded, likely from a drop-down or checklist type menu. And then I'm going to talk a little bit more about templates in the last case study. Better documentation here about the rationale for using the forceps and the laceration repair might have avoided a lawsuit or at least had allowed for a vigorous defense of the care provided. The state where this incident occurred uses a medical panel to review medical malpractice claims. And Latina and I were talking about this earlier, and we think that maybe it's Indiana. I'm not actually sure where this case was from. One of the medical panel physicians reviewing the case was really very defense-oriented. And he indicated how unhappy he was to be making negative findings regarding the OB's care in this case, particularly because the infant was fine. However, he felt he had no choice based on the sparse documentation in the record. Another physician on the medical review panel indicated that his finding was based specifically on there being no detailed description of informed consent, no detailed description of the delivery itself, no detailed description of the repair, and no detailed description of why forceps were necessary. Only the position of the fetus was recorded as a rationale. The medical records did seem to show progress, and in this expert's words, all it would have taken would have been a written note from the obstetrician stating the reason why she decided to move forward with forceps. For example, if the delivery nurses came to her and suggested that the patient was exhausted, a simple note to that effect would have been sufficient here. During her deposition, the OB was asked many questions about her actions on the day of delivery. For example, she was asked, "Is there anything that describes the repair and the details of what you did to repair the laceration?" And she answers, "I don't believe it's in the record." And then the attorney asks, "Okay, so you did not see it anywhere in the chart?" And she answers, "I didn't see it in there." And the attorney asks, "Is there anything in the chart that would in any way indicate that the patient's pushing efforts had in any way diminished?" And again, she says, "Not in the record." And then finally, "Is there anything in the chart that indicates when you utilize the forceps for delivery, whether the station was a +2 or +3 or +4? And again, she says, "It's not in this record." So the unfortunate repeated theme of "it's not in the record," her testimony about her documentation is really obvious here. And of course, there's a whole transcript of her deposition, and these are just a few of the things that she's saying. But in this case, due mostly to this lack of documentation, the claim had to be settled. We couldn't support the standard of care by something that's not, there was no evidence. So let's hear from Dr. McGeorge again about what he thinks this case is about.
The issue with the OB case is that the physician, based on the description in deposition and whatnot, clearly did the right things and clearly had a good thought process. The problem is they didn't document their thought process. They didn't document why they chose to do forceps. They didn't even document a clear repair of the injury that occurred. Anytime you do something that has the potential for a complication, that has the potential for a downstream event that another physician is going to need to know about, or that frankly requires a specific billing code, you need to document it so that you get paid for it, so that the other physicians taking care of the patient know what you did and why you did it, and so that if something untoward happens, you have a good defense for why you did it. And in that particular case, medical decision-making was not documented. The procedure was frankly just not documented. Sometimes it's going to be free text, that is typing things in. But you need to do that because if it's not written, it's something that can be challenged in retrospect. And that's where knowing that thought process, knowing what your considerations were as you were seeing that patient, knowing basically step by step what you did and why you did it is really, really important for so many reasons. Physicians never come to work with the idea of committing malpractice or doing the wrong thing to their patients. We all come to work and we want to do a good job. And honestly, I think we do a good job. The problem is we don't see the documentation as our primary role. We see our primary role as taking care of the patient. But the fact is, if you don't document it, well, as the saying goes, if it's not written, it didn't happen. So you need to chart what happened for all of the reasons that you might think. Big picture, you need to know in the chart what happened accurately so that when someone does review it, for the variety of reasons that the chart gets reviewed, there is a clear picture that emerges.
Okay, so moving on to our initial risk reduction strategies. Document your rationale behind any treatment decision to ensure the medical record reflects the quality of your care. Remember, it only takes a sentence or a brief note to memorialize your decision-making. Type, write, or dictate patient-specific observations when necessary to make the medical record complete. Don't rely on templates, drop-down menus, or checkboxes when additional information is necessary to render a complete picture of your treatment decisions and the care provided. Remember Dr. McGeorge's admonition to document information that's necessary for providing future care, communicating to other providers, and protecting yourself if something goes wrong. Our next case study demonstrates the consequences of poor communication, inadequate documentation, and failure to notify a patient of an incidental finding. We'll discuss key missed opportunities, lessons learned, and strategies for improvement. In this case, a 58-year-old woman presented to the emergency department after a car accident. Upon exam, she complained of pain in the left upper chest and left wrist. X-rays of her wrist and chest were taken. Both X-rays were read by the radiologist, and the wrist X-ray showed no acute abnormalities. And although the chest X-ray also showed no acute abnormalities, the radiologist saw a 17-millimeter nodule in the left upper lobe. In the radiologist's final report, his impression was a 17-millimeter nodule in the left upper lobe apex, and he recommended a follow-up CT of the thorax or a comparison with old chest films. He copied the emergency physician on his report, and that's important. 2 years after the accident, she presented to an urgent care for persistent cough and rib pain. A chest X-ray revealed a 3.3 centimeter left upper lobe lung mass, which had significantly grown since the X-ray taken following the car accident. A subsequent CT scan confirmed the left upper lobe mass, which was highly suspicious for malignancy. Further testing led to a diagnosis of pulmonary adenocarcinoma with metastases to the brain and liver. Although the patient underwent chemotherapy, the disease progressed to stage 4 and she passed away 3 years after the motor vehicle ED visit. Let's take a look at the radiologist's final chest X-ray report from the car accident ED visit. The radiologist identified a 17-millimeter nodule in the left upper lung and recommended further evaluation with a CT scan or comparison with prior films, and no acute abnormalities. The ED physician testified in deposition that it was customary for him to do a preliminary read. He didn't remember reviewing the final report from the radiologist, but if he had, He believed he would have noted the lesion and recommended follow-up to the patient. However, the review of the metadata in the audit trail showed the ED physician had accessed the final report with the exact time he entered and how long he had spent accessing the page with the final report. The timeline revealed the ED physician had reviewed the report 3 times prior to the patient's discharge. I hate this case. The information in the discharge summary was entered by the ED physician. He entered, X-rays were documented as normal. And then we know that the final report had an additional finding of a 7mm nodule, and that the ED physician accessed the final report. But you can see here that it's not there. And we see here that the patient was discharged home with a diagnosis of wrist and chest wall contusion. So it appears from the documentation here that she was never informed of a lesion or the need to follow up. Later, the patient's family filed a lawsuit against the emergency room physician, alleging that the lung cancer diagnosis delay caused her death. According to the plaintiff's expert, the ED physician failed to review and communicate the critical radiology finding and follow-up recommendation, which led to a missed opportunity for early diagnosis and surgical intervention, which at that point had an 85 to 90% curative potential. And the defense experts believed that the ED physician's failure to communicate the incidental finding to the patient was not consistent with the standard of care. And so this was another case that had to be settled because there wasn't the evidence that we needed to defend the case to trial. So let's see what Dr. McGeorge has to say about the incidental findings in this case.
We get incidental findings reported to us all the time. Things come up in radiology reports, consultant reports. They have absolutely nothing to do with why the patient is here seeing us now, but they are important long-term to the patient. It's our responsibility to pass that on to the next provider. And that's going to be their primary care doctor, these incidental findings. If they're not followed up and they lead to an unfortunate outcome, they trace it all the way back to us because we knew about it and should have said something. And to be fair, that is actually part of being a good doctor. I mean, I want the patient to get good care long term, not just for my encounter, but when they go see their doctor. But if their doctor doesn't know that on their chest CT scan for a pulmonary embolus, it just happened to show a funny little nodule that was a concern maybe for a cancer down the line and they needed follow-up, unfortunately, because we work in a busy environment, and frankly, all doctors are busy, it's difficult to remember to check that little box and put that in the discharge instructions. That is a difficult thing. And there are no great mechanisms to close that loop where the radiology report gets back to the patient in a timely fashion so that they get follow-up. If there is an incidental finding on a radiology report, for example, I print that radiology report and I give it to the patient. And I say, this needs to be followed up with your primary care doctor. And that's great for 2 reasons. First of all, when they go see their primary care doctor, if they don't have the radiology report and it's in a different healthcare system and they can't get the records, their doctor says, so you had something wrong on your CAT scan, but you don't know what it is. What am I supposed to do with that? This way, they look at it and they go, oh, I see. So you had this little nodule. We need to follow up. So that's good. The other is, it's a reminder to the patient. They have a piece of paper. They know this is something that needs to be followed up. And I think it really helps emphasize to them the importance of the follow-up. One other interesting nuance now is because patients have access to my chart or their own chart in most electronic medical record systems, you can actually also tell the patient in the discharge instructions, see your chart for the finding and get it followed up. And I would encourage patients, and I do encourage patients, to read their own charts so that they are educated on their own medical process. We need to have systems in place where we essentially flag it. And what I do is I will add that to the discharge instruction essentially as the encounter is going, if I think the patient's going to be discharged, so that it gets passed on. If the patient's being admitted, I always make a note when I'm sending the patient up to the floor and calling report, hey, by the way, this other incidental thing was found. So at least that way the floor knows they need to follow it up upstairs. But outside of putting it in the discharge instructions, giving the report to the patient, and encouraging the patient to read their own chart, things can slip through the cracks. It's not just radiology reports that suggest incidental findings or a need for follow-up. Sometimes we might call a consultant for a specific reason, and that consultant finds something that's an oh, by the way, and they say, yeah, that should be followed up as an outpatient as well. In that particular case, I will often say to the consultant, well, can you discuss that with the patient? And oftentimes, if the patient comes in, sent in by their doctor, you'll call their doctor anyway. It's a good idea in that communication to say, hey, and by the way, this also was found, and you need to follow that up. And to close the loop, you need to chart that you discussed it with the primary care doctor, because otherwise the primary care doctor, they might forget. Honest mistake. It's really important for us to make sure that we include it in the discharge instructions or in the follow-up plan in a way that it becomes incorporated into their problem list. I've been practicing emergency medicine for well over 30 years. And the funny thing is, back in the day, the medical record was considered something that was almost like private proprietary information for the hospital, and we didn't often just give it to the patient, which I always thought was kind of a dumb thing, actually, because the patient has every right to see their own medical record and have access to it. Through MyChart and similar mechanisms, they can read their own electronic medical record. But that's not really enough, because a lot of patients just don't do that. It has always been my habit, actually, to print the report, to print the consultant's recommendation, and physically hand it to the patient. I actually highlight the concerned area and say, you need to take this to your primary care doctor so that they can follow up on it. But the other thing that I will usually always do, if I remember, is I will document in the chart, report given to patient for follow-up. Because really what I'm documenting in the chart is that I told the patient about something that was important for their health. That's not only for my own protection, my liability risk, but also so that if somebody reads the chart later on, their primary care physician, for example, and they just skip past all the blah, 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 and they just go down to the bottom line, my discharge instructions, they will see in my discharge instructions, oh, he found something funny on the radiology report. Oh, what's that? I should look at that. So it helps everybody connect the dots, and it's just another reminder for everyone to help provide the best care for the patient.
So the key takeaways from this case, we're going to add them to our list of risk reduction strategies. Close the loop by ensuring patients are informed of incidental findings and given clear follow-up instructions. Use EHR alerts to flag unexpected findings for follow-up, especially when they're unrelated to the original reason for the test. EHR alerts can serve as a built-in reminder system. They can prompt the responsible clinician to follow up, document, and refer as needed. The EHR alert helps ensure that findings like pulmonary nodules, liver lesions, or unexpected lab abnormalities don't fall through the cracks. And for administrators, establish clear policies for reporting and tracking incidental findings, and educate physicians and other clinicians about the importance of incidental findings and the importance of follow-up. Our final case study can show how detrimental it can be if a template is improperly used. This case involved the treatment of a 73-year-old woman by a primary care physician. She had been a patient for over 20 years. Her history was significant for smoking and COPD. There came a time when she presented for shortness of breath and a cough. Her last 3 office visits became the focus of a lawsuit against her primary care physician. Let's look at the electronic medical record for the first of those last 3 visits. We're going to focus on the section of the chart that documents the physical examination. Although the patient presented with shortness of breath and cough, the physical assessment of the respiratory system was not documented. And these things happen. This wouldn't have been a huge problem in a lawsuit. There was follow-up. She was told to follow up in 2 weeks, and the patient was given Brio. And so that was probably going to be okay. Here's the physical examination note from the second visit, or the second from the last. Here's the note for the respiratory section. And unfortunately, we have another incomplete entry. And if you notice, the entry in this section visit is identical to the entry in the first visit. They both state on auscultation, comma, space, period. Since it's unlikely that a person would type the same incomplete note, the punctuation, we can assume that this is an incomplete use of a template with a failure to complete, or maybe this occurred because a system box was checked and that information then carried forward in the EHR. At this visit, the patient was given Trelegy and she was instructed to follow up in 2 weeks, which she did. And this note is from her third and final visit. And again, we have exactly the same empty note with the same punctuation. This is an excerpt from the patient's emergency department record 2 weeks after her final appointment with the primary care physician. She called 911 because of breathing difficulties, and then she was hardly able to speak when EMS arrived. By the time she reached the hospital, she was nonverbal, and then the patient was hospitalized and ultimately diagnosed with stage 4 lung cancer. She died 4 months later. Her family filed a wrongful death lawsuit against the primary care physician, and they alleged that the delayed diagnosis of lung cancer resulted in the patient's diminished life expectancy. Here's a document that was filed by the patient's family. This is the complaint in the lawsuit, and they argue that nothing was done by way of examination. And as reflected in his records, he, who is the primary care physician here, did not perform any type of respiratory examination. And although the physician surmised that he simply forgot to document his respiratory examinations, the family used the template-generated incomplete respiratory examination documentation and the patient's emergency room presentation to support their allegation that no examinations at all were performed. So the implication here is that based on her presentation in the ED, 2 weeks following her final office visit, the primary care physician would have noticed something was significantly wrong if he had just done an appropriate examination, and that was the argument. So the physician was deposed in this case, and while he was certain he examined the respiratory system and his plan was appropriate, he didn't have a clear memory of what he did. And like many lawsuits, his deposition occurred more than a year later, and the physician's memory of what had occurred had just faded. And then that long afterwards, he was left with his documentation. There's nothing that you can do after it happens. So the lawsuit settled, and it was partly because the documentation didn't support the physician's testimony. And the error in these records might seem obvious here because we have the clinical notes all blown up on the screen, but it's worth thinking, could this happen to you, right? In the midst of a busy day, are you being methodical in reviewing every section that's generated by your templates? And in addition to the templates, is your EHR copying forward parts of your chart? Do you know? Have you reviewed your charts lately? It's really important to check your record every once in a while, because you might see that the EHR is doing something that you didn't really expect that it would be doing. So let's return now to Dr. McGeorge for some commentary on documenting during a busy day.
We're all busy. We want a chart as quickly as possible. And oftentimes that does mean copying some little phrase and pasting it somewhere else just for convenience, because a lot of the chart is often repetitive. The thing that's important, though, is the chart needs to reflect your thoughts. So if you are cutting and pasting someone else's thoughts and they are either poorly phrased, poorly punctuated, misspelled, it will be obvious that you just cut and paste someone else's thoughts. And while it might be convenient for billing purposes, and it may actually be conveying some accuracy in terms of the chronology in the chart, if something untoward happens, and someone looks back at that, and they identify those misspellings, misphrasings, poor punctuation, whatever, it's going to be obvious you just cut and paste, and it's going to make it look like you didn't think about the case. You didn't really take care of the patient. You didn't really document your thought process. And that's just embarrassing. I would really encourage people to document at least some of the chart in their own words, in the way they would do it. Some parts get carried over naturally. Charts now, because of the electronic medical record, auto-populate actually. And I actually super dislike that, because oftentimes it auto-populates either old data that's no longer accurate or pointless data that I'm not interested in, at least in the emergency medicine chart. But for internal medicine, I get it. Especially progress notes. Say the same thing day after day. You know, I mean, in the old days, we used to say patient, because it was a short progress note, we'd say patient doing well, write a brief physical exam, and saying continue present management. We wouldn't even write that. We would just say CPM, A/P colon CPM, assessment plan, continue present management. Now, because of billing recommendations and all that, people just cut and paste what they did from the day before and the day before that and the day before that and so on. And oftentimes those are cut and paste from another person's note. You need to put your own original thought and your own original stamp in the note so that it's clear that you participated in the patient's care. Copying and pasting is something that we do routinely. It's totally fair. It's totally reasonable. The key is you don't want to just keep doing it day after day repetitively, especially even if it's in your own notes necessarily. You want to make sure that you are clearly indicating in the chart that you've made some new thought processes. You need to always envision that the chart is going to get blown up bigger than life in front of a jury. And a jury is going to see that, and they're the finder of fact. They are going to be left to make their own decision about what's up there. And quite honestly, there are some things that are just so glaringly obvious that you are just going to look, well, foolish. So that's not to say that you need to correct every note for spelling, punctuation, and phrasing. That's not the point. The point is, if it can be clearly demonstrated that you didn't really put a whole lot of thought into these notes and you just cut and paste a bunch of stuff, that is just going to look embarrassing. And that is not something that is going to be easy to defend. You're just making it harder on yourself. I mean, big picture, we're all going to get sued at some point in our lives. We are all going to experience the legal system. We are all going to get tagged with a lawsuit at some point in our lives. The best thing that you can do, though, is prepare yourself by having a good chart that is easily defensible.
Good advice. So continuing our risk reduction strategies from the internal medicine case. Be cautious when you're using templates and copy forward. Sometimes there are automatic settings in your EMR, and copying forward can perpetuate medical errors and create liability issues. When you're using templates and copy forward, methodically review your records to catch errors and make necessary changes. As Dr. McGeorge explained, be sure to add your own original thoughts to the note and make sure that the note reflects the actual visit that occurred. Perform quality checks. It's not something that anybody wants to do, but it can show you where you're doing a good job or show you when things are drifting into bad habits. When you and your staff are reviewing your medical records, you want to ask yourself, is the note clear? Do you know what happened? Is it easy to understand? Did the system auto-populate something? And does that something need to be corrected? Does the note make any sense at all? We've seen in cases where an infant is noted to be alert and oriented to person, place, and time. So the templates are doing this, and if you don't catch it, it's just going to continue. And finally, just like Dr. McGeorge says, if somebody pastes your EMR note up on a huge screen like this, is it going to be something that you're proud of that shows that you met the standard of care? And if it doesn't, it's something to think about, So I'd like to wrap up this presentation with some final thoughts from Dr. McGeorge.
Doctors provide good care. The documentation needs to reflect that good care. The fact is, documentation is a burden. I'm not going to deny it. I'm not going to pretend that I love documenting. I don't love documenting at all. But we have to do it. And if you're going to do it, you should do it right. And you should do it with certain things in mind. And one of them actually does have to be protecting yourself a little bit with some forethought. The one thing that I always ask residents to consider is, if you're wrong, what can you write in the chart to help explain why you made the decisions you made? We don't intend to be wrong ever. But one of the things that we need to consider is, what are the other possibilities and why did I take this path instead of that path? Well, it's usually because that path was something we didn't really need to follow anymore. We ruled it out. Well, explain why you cut that path off, why you ruled that out. That makes all the difference. You just need to have considered that path thoughtfully. And that's what you need to document. Not pursue every dead end if you think it's going to be a dead end. Oftentimes we can go back and rely on our standard custom habit and routine. But the fact is, that is easily challenged because memories fade over the years, that kind of thing. Contemporaneous documentation, what you wrote in the chart in the moment, is actually the most important thing and the most reliable. And anytime you do something that is critical, a procedure that is going to affect an outcome, that changed an outcome, a decision that you made that was a branch point in the patient's care, that all needs to be documented. Why you did it, how much you did, how much thought you put into it, what the consequences were, how you informed the patient even. Those are all critical elements of the chart for so many reasons. There is no specialty where I would consider documentation to be easy. The electronic medical record has just complicated all of our lives. It was supposed to be easier. It's not. Simple fact. I'm going to just admit that to everyone out there watching. But we need to work with the electronic medical record. And filling it out is part of our job now. And we just need to accept that. And we need to use whatever tools are at our disposal to make it easier. That may mean sometimes template use. That is often going to mean, in my case, dictation use. Our role as a physician is to take care of the patient. But the fact is, when we take care of a patient, we need to document why we did what we did. And part of the reason is you want to demonstrate in the chart that you are a good doctor and you did all the right things. And if you don't do that, not only can you not bill for it, not only is that not communicated to future physicians or future people looking at the chart, but you also can't defend yourself if something does happen. Doctors provide great care. It just needs to be reflected clearly in the chart how that great care was delivered.
All right, I hope you enjoyed this today. Thank you so much for inviting me in and letting me share our risk management materials with you. And we have a risk management department, and I don't know if Brent wants you to contact us directly or we can contact Brent. What?
If you have any questions and you want to utilize them as a resource, or if you'd like for us to advocate on your behalf and answer a quick question, because we know that you all have patients that are busy as well, we'll be happy to do that as well.
Yep, I'm there 9 to 5 every day in Minneapolis, waiting for your calls. We have a full risk management department filled with clinicians and lawyers like me and office managers and risk managers from hospitals. And if I can't answer your question, I'm going to call up my friend Jerry Ann, who used to be an oncology nurse, and ask her, and she might have to call our PA, Kelly, and ask Kelly. But we do try to get your questions answered the best that we can. And does anybody have any questions about the cases or your liability insurance or what the snow is like in Minneapolis or?
No, that was really good. Having been sued, I can tell you everything, and I've reviewed a bunch of charts for other lawsuits, and everything you said is very, very accurate and embarrassing when you find your own stuff that is incomplete. But, you know, the problem is that we're pulled in one direction. If we don't document everything, whether it's meaningful or not, you can't go for it. And the charts are, most of what's in a medical record now is meaningless, almost all meaningless. You have, it's like where's Waldo, you know?
Right.
Where, there, that's not, no, that's not, he's over there. You know, and that's the problem. So I don't know how to fix it.
Well, I think that Dr. McGeorge would say, if your template doesn't allow it, that you need to dictate something in there. So templated information is not always going to be satisfactory. And if you feel like it's not complete, that's what you should do. And that's what I would say too. But you know, I'm your malpractice defense insurer. You know, I want you to show that you complied with the standard of care, and that's what we're looking for.
Thank you.
Hey, Mary Lynn,
Yeah.
we had this discussion with Brent earlier in the office, but maybe speak to AI and these new, technological systems that are coming into play as far as charting and whatnot, and what the advantages and disadvantages of that might be.
Right. So what I'm going to recommend to you, Miller, is our loss prevention seminar, which is 2 hours of AI. So it tells you everything that you want to know about AI in healthcare right now. I'm not going to promise that in 2 months it's going to be accurate, but like right now, it's pretty good. And as far as like ambient scribes, which I think maybe what you're talking about is like the scribe, the microphone is listening to what is going on in the room, and then it's taking the contents, taking the recording, and it's putting it in a document, and it's weeding out I saw your sister at the grocery store, and so it's hopefully taking all the irrelevant stuff out. And we don't know yet whether it's going to be better or worse than what we have now.
So, I find it a real pain in the ass. And why I think that, because we've tried this, and I don't use your clinic things. I'm just a contract for the pediatric hospitalist. I tried it in EMDs, and I thought it was a real pain in the ass because I have spent my whole practice time learning how to filter out what's important and what's not important. And all of a sudden, a bunch of stuff that is said by the parent, not by me making recommendations, ends up in my note, and I have to spend more time wiping that out. And then there's the risk of, can that be found out later that the parent said that? No, I can't risk having that in my note. And I really need to see, okay, what's the benefit of having this? Because I'm not seeing it yet. Maybe it makes me bump up my charge capture a little bit, that I addressed more problems, but I see it as a real liability.
Yeah, and I think that like any new technology, this is just the beginning of this, just the beginning of the technology. And we know when you think about when Dragon started and how horrible the Dragon dictation was when it first started, and you were like training it on your voice, and it was making these huge mistakes. And and it's better, right? But I think that right now, what you're doing is exactly right. There are going to be situations where you're forced into using a technology that's not working for you. And hospitals and medical practices make decisions sometimes that aren't the best as far as risk or patient safety is concerned, but you learn to look at it, figure out what it's doing wrong. And I mean, I'm sure that it's really difficult if you're like,
No, you have to, because I am a part of my practice, so I can tell it to take a hike.
yeah,
I'm not using this, and you know,
Okay.
until it gets better, we're not going to use it.
I think that that's an excellent decision. And I also think that there are some tools that are going to be better than others. Per usual, like the free tools are not going to be quite as good as the pricey tools. And I mean, we just have to wait. We have to wait and see. And you have to advocate, I would say, and I know that this is not going to sound great, but I mean, if a tool isn't working for you, you have to go to Brent and you have to say, Brent, this tool really stinks and I don't want it. I don't like it, and these are the reasons that I don't like it. I think it's exposing me to liability. I'm not going to use it. Whatever, But I mean, administrators don't know that something doesn't work until you tell them it doesn't work. And I think that there can be good things if the AI scribe stuff gets really sophisticated and it frees you up from documenting and it figures out to do what it's supposed to do. And then, it's going to be a great thing. But as I said, it's only been around for what, 2 years? And it's not long enough to really, but I imagine it's really horrible and frustrating and to deal with. Thanks. Yes, John?
I was just going to add, the public seminar, online seminar, 2-hour seminar that Pro Insurance offers each year, as Mary Lynn referenced, the subject is AI this year. And I will make sure that we get that information to Brent and to Beth, and they can distribute to you all. You simply need to have you need to set up a password, you can go in, it's free, no charge to take it. You get 2 Category 1 credit hours as well for doing that. But it's appropriate and certainly timely. And we'll make that available to you all as well.
And the people who wrote the program and presented are really super smart and they're funny. So it's a good program. If you're looking for, if you want to learn more about it and you want some CME, and you have a little time. Anyone else?
Any other questions for Mary Lynn?
Okay, thank you.
All right. Thank you for having me.